So he will speak about patients with transient atrial fibrillation. Kurt?
So, Madalena, Claudio, ladies and gentlemen, triple therapy in ACS patients with atrial fibrillation. Great topic, great guidelines, but eventually we move to another strategy, at least in part of our patients. So these are my COIs, and so why do we talk about triple therapy? We talk about it because we need dual antiplatelet therapy in an acute coronary syndrome after coronary stenting, even if the patient is stable. And we may need an oral anticoagulant in patients with atrial fibrillation, also if it's transient or paroxysmal. So what do we know about atrial fibrillation? We know that the best anticoagulants seem to be the NOACs, and this is from the recent guidelines, ESC guidelines. They seem to be better, safer than vitamin K antagonists, although they are not used in about 30-40% of patients, at least in Austria, and I think it may be similar here in Italy. We have now the so-called non-valvular atrial fibrillation with an increased thrombotic risk. I come to this a bit later, in combination with a PCI. So we need, in theory, triple therapy. But what should we do in patients with a high bleeding risk? Should it really be triple therapy? And should it be triple therapy for a short or a longer time? Or could we even do a dual therapy in these patients? So I think this is the most important question at the moment. I show you a case, and it's a case from my hospital, a 76-year-old woman. She has chest pain and palpitations since 4 hours. It's the first time that she feels chest pain, but she had a history of recurrent palpitations lasting up to 8 hours in the past. This situation was self-limited and occurred 4 to 5 times a year, but she never had an ECG. So we have no clear diagnosis, but it sounds like eventually atrial fibrillation. She has also a history of hypertension, and she had a bleeding gastric ulcus 2 years ago. Her medication at the moment is an ACE inhibitor, and the vital signs in this patient were more or less okay. She had a tachycardia, 165 beats per minute, and she had a relatively low blood pressure based on the tachycardia, but she felt otherwise well. She received an ECG quickly, within 10 minutes, in the emergency department. ZNE is in German, means Central Emergency Department. And this is her ECG. And I think you clearly can see that it's a tachycardia and it's atrial fibrillation. There are no clear signs for ischemia in this ECG. Now, again, the case, and on the bottom you see the biomarkers. And she had, when she came, a normal troponin I give you here just a normal level. It's less than 50 nanograms per liter in the test system we are using. It was after 1 hour 27, but it increased after 3 hours. So she has a tachycardia, she has an increase in troponin, she had chest pain, her creatinine was 1.2 milligrams per deciliter, and the GFR was 48, so slightly reduced. So my question to you, so it's to you to work, how to proceed. So this is a patient with an increase in troponin based on tachycardia. She has also pain, she has hypertension as a risk. She's 76 years of age. Could it be an ischemic problem, a coronary ischemic problem? So what would you do? Do an angiography in this patient within 24, 48 hours? Would you just observe the patient, or would you send her home? I don't think anybody would send her home. So who is in favor of angiography? Please raise your hands. Who is in favor of just do some observation and decide later? So that's the majority here. So we are very aggressive in Vienna, so we did an angiography, and this is the result. And what you see here is in the LED, you see here a stenosis. It doesn't look very severe. It looks like 50-60% of lumen narrowing, so we still were not quite sure. We did an FFR, and the FFR was 0.7, so this is a significant stenosis, and the patient received a stent. Now we have the situation, a patient with atrial fibrillation. Meanwhile, atrial fibrillation was gone. A patient with an, we think, acute coronary syndrome, at least the patient received a stent. Now, what about her JETS VASC score? And I will show you this. She has hypertension. She's older than 75 years of age, and she's female. And now she has also vascular disease. So she gets another point, and in total, this would be 5. And 5 is a high risk for a thrombotic event, for stroke or systemic embolism. So what about her bleeding score, her splat score? Again, hypertension, then she has one of both. She has slightly reduced renal function. She had no stroke, but she had bleeding. I count this a bit later, and she's elderly. So she gets here also some points, and this, if you add the bleeding 2 years ago, I don't know whether we should add, it's a discussion, but anyway, she has 3 to 4 points in her splat score. Now she clearly needs combination therapy, and this again is the guidelines in patients with acute coronary syndrome. Patient with an increased bleeding risk compared to the risk for ACS or stent thrombosis. So this was an easy to handle problem in her LED. It's a short stent, so I think the risk for stent thrombosis is relatively low in this patient. The bleeding risk is relatively high. So we'd look at the right-hand side, and the guidelines tell us do triple therapy for 1 month, then dual therapy with an antiplatelet drug. You can choose between aspirin or clopidogrel in combination with an oral anticoagulant up to 12 months, and finally go for monotherapy with an oral anticoagulant. Now, what did we do? So the patient had an admission ACE inhibitor. During PCI, she had aspirin. She had clopidogrel. We used clopidogrel because we knew that we had to put the patient on a combination therapy, and so now the guidelines tell us use clopidogrel in this case, and not the stronger P2Y12 inhibitors. And we like to use bivalirudin in ACS patients with an increased bleeding risk. So this is maybe not the case in your country. It's also not the case in most institutions in my country, but we still use it. And what have we done at discharge with the patient? We used aspirin for 1 month, clopidogrel 75 milligram once daily. Rivaroxaban, we used 15 milligrams. So the guidelines tell us use the lowest doses that has been tested. And we come to this in one of the next presentations. We eventually could have also used 20 milligrams, but we used 15. So we are very reluctant to get bleedings in these patients, and she had still her ACE inhibitor. So this is a pioneer-based situation. We have 2 studies now that show us that we eventually can do dual therapy in patients with high risk. One study is the pioneer study, and here you would just skip aspirin when the patient leaves the hospital. So you have it on board during the acute intervention, but you then stop aspirin and you give only dual therapy, clopidogrel 75 milligram once daily, in combination with rivaroxaban 50 milligram once daily, and with an ACE inhibitor. And also here you can ask, is 15 milligram the right dosage? Because in the study in Pioneer, 10 milligram was used in patients with an increased bleeding risk, which was defined as a reduced GFR. It was 48, so we decided to use the 15 milligrams. Now this is the Pioneer data. Maybe you know this data. There were 3 different strategies in these patients. They either received triple therapy with a vitamin K antagonist, aspirin and clopidogrel, or they received a triple therapy with rivaroxaban 2 times 2.5 milligrams, very low dosage in combination with aspirin and clopidogrel, or they received rivaroxaban 15 milligram in combination with clopidogrel 75, as we could have done in our patient. And this is the primary safety endpoint. It's bleeding complications, and you see that the bleeding is lower in the rivaroxaban arms. It's significantly lower. So what about the efficacy, the ischemic events? And this study is not powered really for ischemic events, but it shows essentially no difference. So I think we can feel relatively safe. So it doesn't work worse compared to triple therapy. Dual therapy doesn't work worse, but it's much safer. Now, another option would be to do a redual PCI-based therapy. So this is now the second study that have been published quite shortly, several weeks ago at the ESC meeting. And then you could do about the same. You could you could skip aspirin and put the patient on clopidogrel and dabigatran, either 2 times 110 milligrams per day or 2 times 150 milligrams. So again, in this situation with a high bleeding risk, we would decide to use the 110 milligram twice daily. So this is optional. I think it's at the moment we are not able to prescribe this, but we are well able to prescribe rivaroxaban based on the Pioneer study, which has been published about 1.5 years ago already. Now, these are the real PCI data. On the left-hand side, 110 milligram. Dual therapy, which means clopidogrel in most patients. That's only 12% of patients that received ticagrelor. I come to this a bit later. But 88% had clopidogrel in combination with dabigatran. It's a blue line, and the triple therapy is seen in red, and there's again a clear reduction in bleeding events. And on the right-hand side, you see also a significant reduction in bleeding events if 150 milligrams are used. So it's still the question which of the two dosages for which patients are ideal, and there's no clear data, also not at the American Heart Association, we have been a few days ago. So this was not answered. So they have several post-hoc analysis, and they compare age groups, they compare ticagrelor versus clopidogrel. I come to this. But they have no clear data at the moment which patients should use which of the two drugs. And this would be an important information. So this, again, is the ischemic events, which is exactly the same with dual therapy compared to triple therapy. So I think a proof of concept. I think it is enough to do dual therapy in many patients with an increased bleeding risk. And we should eventually we are not forced to do triple therapy in all of our patients. Now, this is data about the 110 and the 150 milligrams in comparison with warfarin, but just look only on the 110 versus the 150 milligram. And what you can see here is that you have a bit higher ischemic complication rates in the 110 milligram compared to the 150 milligram, but compared between the 110 and warfarin and the 150 and warfarin, there's no statistical difference. It seems to be that 150 milligram eventually is more effective, but we don't have clear data at the moment which patients should get the higher dosage here. And this is data about age. And on the left-hand side, in the upper part, you see the elderly patients. So these patients are older than 70 or 75 years, I don't remember exactly at the moment. And what you can see here is if you have an older patient and use 150 milligrams of dabigatran, then you have then you have an increased bleeding rate. So here warfarin would be even safer. And if you use the 110 milligram, you are more on the safe side. So maybe this is one thing we should have in mind, and this eventually would drive us to use 110 milligram in our patient. In the non-elderly, there's essentially not really a difference. And now if you look at ticagrelor use, yes, if patients have ticagrelor, and you see in the upper part here, you see the 110, and here's in the 150 milligram. If you compare this with no ticagrelor use, you see that there is more bleeding complications with the 150 milligram. So again, something which we have to know exactly which patients, which bleeding risk would allow us to use a higher dosage, which eventually has a better anti-ischemic effect. Now, I just come back to this slide. So these are the guidelines at the moment, and I think what we could do in the future, we could think in our individual patients whether triple therapy, even for 1 month, is necessary, whether we can do dual therapy in many of our patients. And this is my summary slide. So in patients with an increased bleeding and low to moderate ischemic risk, a dual antithrombotic strategy including a NOAC and clopidogrel should be preferred over triple therapy. We have data for rivaroxaban and dabigatran, not for the two other NOACs that are available. Triple therapy, individualized for 1 up to 6 months, should be offered to patients with a low to moderate bleeding and increased ischemic risk. what is an increased ischemic risk, recurrent MIs, history of stent thrombosis, a complicated coronary anatomy could be an increased ischemic risk. Then rivaroxaban or dabigatran are currently the NOACs of choice in combination with mainly clopidogrel. There are ongoing investigations with apixaban, the Augustus trial, or edoxaban, the Entrust trial. So these investigations are ongoing for the next 1 to 3 years, so we won't have reliable data here. And the use of ticagrelor has been proven in combination with dabigatran in ACS patients with atrial fibrillation. It might be an option in clopidogrel non-responders or patients with high ischemic risk, but the 12% of patients that were on ticagrelor does not allow to use this stronger P212 inhibitor in most of our patients. So thank you so much for your attention.